Welcome back guys. Now in this video let's discuss about cardiomyopathies. Cardiomyopathies. So what exactly are these cardiomyopathies? Cardio means heart, myo means muscle, the cardiac muscle, and pathology. Pathy means a pathology. Okay. So cardiomyopathies are some problems with the heart muscle. So what exactly are these cardiomyopathies? How many types are there? There are 3 types of cardiomyopathies. Okay, 3 types. So what exactly are these 3 types? Include the first type is called as hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy. See, here itself I am giving you the clarity. Imagine if I am the person who is suffering with hypertension or conditions like aortic stenosis. See, this hypertension and aortic stenosis are going to cause hypertrophy of the left ventricle. See, but that hypertrophy should not be called as hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy are these cardiomyopathies, whatever I am discussing, these 3 types, they are not associated with any heart related problem. They are not associated with ischemia, they are not associated with any valvular lesion. So these cardiomyopathies, whatever I am talking, they are not associated with any notable heart related problem. Okay, they are occurring, everything is proper, everything is normal. Okay, there is no valvular lesion, there is no ischemia, there is no myocardial infarction, but the ventricular myocardium, it is undergoing hypertrophy. Okay, so this hypertrophic cardiomyopathy, remember the first point, hypertrophic cardiomyopathy, it is not because of aortic stenosis, it is not because of hypertension. If there is hypertension or aortic stenosis, yes, it do causes ventricular myocardium to undergo hypertrophy, but that is different. This is different. Okay. Now, the second type of cardiomyopathy is dilated cardiomyopathy. See, even if the person, for example, if the person is suffering with congestive heart failure, the heart is failing to pump the blood, there is congestive heart failure. Now this congestive heart failure can lead to the dilation of the ventricles. That is different. That is ischemic cardiomyopathy. But in this condition, the dilation of the ventricles is not because of ischemia. The ventricles are getting dilated. We don't know the exact reason why. I will give you the risk factors, but we don't know the exact reason why. There is no ischemia, nothing. Heart is absolutely normal. Okay. Next thing. The third type of cardiomyopathy is restrictive cardiomyopathy. Okay, hypertrophic cardiomyopathy, dilated cardiomyopathy, and restrictive cardiomyopathy. There are 3 types of cardiomyopathies. Now, let me begin with the first one. Look here. On your left, whatever you are seeing, okay, on your left, whatever you are seeing, please look here. This is the interventricular septum. Okay, this is the interventricular septum, and this is the left ventricular muscle. See how much thicker the muscle is. So much, right? So what is happening here is the hypertrophy. Or you look here, please concentrate here. When compared to the normal heart, this is the normal heart. When compared to the normal heart, see, there is septal hypertrophy. The septum is getting too much hypertrophied. Okay, there is too much septal hypertrophy. This is called as asymmetrical septal hypertrophy is happening. Why this is happening, I will tell you later. Because of some gene mutations, it will happen. But now what is happening in hypertrophic cardiomyopathy? Point, there is asymmetrical septal hypertrophy. It's not the concentric hypertrophy. It's the asymmetrical septal hypertrophy is happening. The septal myocytes are becoming bigger and bigger in size. They are demanding more oxygen, that will cause a problem. And not only that, you can appreciate because of this septal hypertrophy, the left ventricular outflow tract. See, this is a normal left ventricle. Okay, concentrate here. This is the normal left ventricle. Okay, now this is the outflow tract, right? Aorta is the outflow tract, the aortic valve is there. But because of this asymmetrical septal hypertrophy, what is happening to the left ventricular outflow tract? It is getting narrowed. Okay, now do you think blood can go easily into the aorta? Definitely not. So there is stenosis. Where? There is narrowing. There is stenosis. Where? Below the aortic valves. There is no problem with the aortic valve, but below the aortic valve, please concentrate here. Below the aortic valve, there is narrowing. So this is called as subaortic stenosis. Okay. So these are the points which I want you to know. So the image, whatever I am showing you here, this image is talking about the hypertrophic cardiomyopathy. The one more important point which I want you to know, which was asked in the previous exams, is that look at the left ventricular cavity. See this left ventricular cavity, because of this septal hypertrophy, it's looking like a shape of a banana. Now it's too much narrowed down. So you will see banana shaped left ventricular cavity. So the shape of the left ventricle, it looks like a banana. Okay, but because it's too much narrowed. Later, what else you should know? See here, whatever you are seeing on the top. See, these are the normal myocytes in the ventricle. This is how the histology of the normal ventricular myocytes. See how beautiful they are. They are arranged very much in a parallel fashion. Okay, they are absolutely parallel. You can see one myocyte is in contact with other myocytes. There are intercalated discs. So these are all the myocyte bundles. Okay, this is something normal histology. Okay, so in between them the intercalated discs are there. This is something normal. But if a person, if he develops hypertrophic cardiomyopathy, then what is the histological appearance? This is the keyword actually. Now, if you do the histology of this hypertrophic myocardium, then you will see there is disarray, myocyte keyword. So there is branching. Okay, you can see this excessive branching is there. Okay, so this branching is called as myocyte on microscopic examination. On biopsy, what you will see, biopsy, you have done the biopsy, and upon microscopic examination there is myocyte disarray, means excessive branching. Myocyte disarray means excessive branching of myocytes. Next, after this, what else you should know? See, in hypertrophic cardiomyopathy, HCM, or this HCM, there is one more synonymous term. Okay, there is hypertrophic obstructive. There is hypertrophy, septal hypertrophy is there, but it is also obstructing. Obstructing what? Left ventricular outflow tract. So that's why it is called as hypertrophic obstructive cardiomyopathy. How come? Okay, HCM and HOCM, they are one and the same. HCM means hypertrophic cardiomyopathy. HOCM means hypertrophy is there along with obstruction. Where is obstruction? Left ventricular outflow tract. So HCM and HOCM, they are one and the same. Now, what exactly is this HCM? It's an autosomal dominant condition. Okay, it's autosomal dominant condition. Because of what? Because of a gene mutation. Which gene mutation? MYH7 gene mutation on chromosome number 14. See, this gene is mutated. Because of this gene mutation, what happens? Which proteins are going to be defective? Myosin binding protein. Okay, myosin binding protein or beta myosin heavy chains. See, these are going to be defective. Because of this MYH7 gene mutation, these proteins, myosin binding proteins and myosin heavy chains, beta myosin heavy chains, they are going to be defective. So, because of this gene mutation, what is happening? I have already taught you. There is a symmetrical septal hypertrophy. Okay, there is asymmetrical septal hypertrophy. See, when a patient is having aortic stenosis, again I am repeating, when a patient is having aortic stenosis or when a patient is suffering with hypertension, then also left ventricular size is going to be increased. That is a concentric hypertrophy which is seen as a result of hypertension. But here in this condition, hypertrophic obstructive cardiomyopathy, it's because of a gene mutation. Okay, so there is asymmetrical septal hypertrophy, and usually remember this condition HCM, it is coming in the families. It's genetic, it's autosomal dominant, it's coming in the families. So usually they will give you in the history that some of the relative, sibling, okay, some of the relative have died with sudden cardiac death. Okay, there is history of sibling died with sudden cardiac death. Okay, there is this one sibling present who is simply dancing, suddenly dead. Simply playing, he's playing in some school sports, suddenly dead. Now, why this sudden cardiac death will happen, we'll discuss later. But usually it's an autosomal dominant condition. It's present in the families. The father or brother have suddenly died with a cardiac, sudden cardiac death. Okay, that's the important point which I want to put into your mind. One more important point is, see, there is asymmetrical septal hypertrophy, no? Asymmetrical septal. See, this is useless muscle. The septa, the septal myocytes, they are not involved in the contractions. But because of the increased growth of these muscles, they will consume more and more oxygen. So that can lead to ischemia. Okay? Ischemia and hypoxia. So, because of this asymmetrical septal hypertrophy, there will be subendocardial. We know that subendocardial region in the heart is more prone to ischemia. So now even in this condition, there is the bigger, bulkier myocytes. Okay, bulkier tissue is there. Now it will demand more and more oxygen. It will use up more and more oxygen. So that can cause relative ischemic environment. So because of this asymmetrical septal hypertrophy, there is a chance of subendocardial ischemia. Okay. Next, what else you should know is, if a person, imagine if a person is having this hypertrophic obstructive cardiomyopathy, okay, HCM, he is going to have what kind of problem mainly? Systolic problem or diastolic problem? The main problem in this condition is diastolic dysfunction. Why diastolic dysfunction? Why? Because of this asymmetrical septal hypertrophy, because of this thickening of the muscles, the left ventricular cavity size is going to be greatly compromised. Now the left ventricular cavity, just like a banana shape, very thin, very small cavity is there. Now whenever there is a small cavity, do you think proper filling will happen during a diastole? During diastole, normally the ventricle, it should relax and it should have to fill the blood. Okay, now it should have to get its end-diastolic volume, it should have to get its preload. Because of this hypertrophy, now the left ventricle, it is not filling properly. Because of this hypertrophy, the left ventricular cavity size, okay, diastolic dysfunction because left ventricle, LV cavity size is going to be decreased. Okay, left ventricular cavity size is going to be decreased, compromised. Okay. Next, what else you should know? So the filling is less. First of all, it's not getting properly filled. It's a diastolic dysfunction. Upon which one more problem is there. Outflow tract obstruction is also there. It's not filling properly. So there is not sufficient amount of filling. Okay, going on. Okay, life is going on. But when this fellow, when he start to do some sports activity, okay, now when this person start to do some exercise, what will happen? Now his heart rate increases, definitely because of the sympathetic activation, his heart rate increases. Whenever there is tachycardia, whenever there is heart rate, whenever there is increase in the heart rate, think logically and tell me, what happened to the diastolic time? Diastolic time is going to be reduced. Whenever the diastolic time is reduced, automatically the filling time, the diastolic time is nothing but the filling time, right? The filling time is going to be reduced. So less filling will happen. Already the cavity size is less. Now if the person is trying to do some activity, his heart rate increases, the diastolic time decreases. When the diastolic time decreases, less filling will happen. So what happened to the cardiac output? Decreases. When the cardiac output decreases, what happens? Syncope. Suddenly the patient will go into the unconsciousness. So with exertion, okay, let me write it here. It's a diastolic dysfunction. So what happened to the end-diastolic volume? Decrease in the end-diastolic volume. Okay, left ventricular cavity is small. So what happened to the end-diastolic volume? End-diastolic volume is nothing but the amount of blood that is filled in the ventricles. It's going to be less. So end-diastolic volume, at the end of the diastole, see at the end of the diastole, how much blood is going to be there in the ventricles? Because of the small cavity, small blood, little blood. Now, because of this decrease in the end-diastolic volume, what happened to the stroke volume? If EDV decreases, stroke volume decreases. Whenever the stroke volume decreases, already he is having less stroke volume. If he do exercise, what happens? Heart rate increases, diastolic time decreases. If diastolic time decreases, time for filling decreases, less filling will happen, that will lead to syncopal attacks. So the patient is going to have syncopal attacks. with exertion. So with exertion, the patient is going to have the syncopal attacks. That's why whenever this patient, okay, whenever he does some activity, he will go into unconsciousness. Okay, that's the point which I want you to know. Now, apart from that, what else you should know is, in this HOCM, hypertrophic obstructive cardiomyopathy, there is subvalvular, means already I have taught you, below the aortic wall, there is no problem with the aortic wall, but below the aortic wall, due to asymmetrical septal hypertrophy, there is narrowing. So this is called as subvalvular aortic stenosis. So there is subvalvular aortic stenosis. Now one more problem which happens in this hypertrophic obstructive cardiomyopathy is systolic anterior displacement. Systolic anterior displacement of mitral valve leaflet. Mitral valve leaflet. If you ask me, already I have taught you what is subvalvular aortic stenosis. Okay, below the aortic wall there is stenosis that will decrease the cardiac output. It's narrowing, right? And not only that, there is systolic anterior displacement of mitral valve leaflet. What exactly is this? Which is also called as it is called as SAM, systolic anterior displacement of the mitral valve. What is this SAM, sir? Now look at this image. Now concentrate here. See, whenever there is stenosis here, see, already there is stenosis. Okay. Now, because of the stenosis, what happened to the outflow? Outflow is getting narrowed. Now it's like a funnel shape. Now it's very much funnel, like a funnel. Now whenever the blood is going into the aorta, the velocity of the blood is going to be greatly increased. Already there is a narrow, right? So whenever the blood is passing through such a narrow funnel, the velocity with which the blood is going into the aorta increases. Okay. Now what happens whenever there is this super high velocity of blood going into the aorta? This velocity will actually cause displacement of the mitral valve leaflet. So here this is the mitral valve leaflet, right? This is the leaflet. This is the anterior leaflet of the mitral valve. This high velocity will actually cause the displacement of this mitral valve. Just let me give a small example. Whenever you go to some railway station, your parents will ask you not to stand near to the tracks. See, on the tracks, the train is going to go with a very high velocity. Okay, 150 kilometers per hour. Now, whenever there is something which is going with very high velocity, it will actually attract you, it will drag you towards the train, it will drag you, that velocity will drag you. In the same way, whenever there is a subaortic stenosis, there is a narrow or funneling of the left ventricular outflow tract. Whenever the blood flow is going through this outflow tract, okay, it will create a great velocity that will actually cause the displacement of the anterior leaflet of the mitral valve. So now tell me what happens. So because of this displacement, now the mitral valve, which was supposed to be closed during systole, during left ventricular contraction, the mitral valve was supposed to be closed. Now what happens? Because of this systolic anterior motion, because of the SAM, now the blood will also go into the left atria. Okay, blood will also go into the left atria. So there is mitral regurgitation. Because of this SAM, systolic anterior motion, there is mitral regurgitation. That's the important point I want you to know. So that will cause a murmur. The systolic anterior motion will lead to the mitral regurgitation. That will cause a murmur. Okay. So let me write here. Okay. See both this subvalvular aortic stenosis as well as systolic anterior displacement of the mitral valve. What they are doing? Both of them, first let me write, they are contributing, both of them, they are contributing to what? They are contributing to left ventricular outflow tract obstruction. Okay. So because of the displacement of the mitral valve and because of the asymmetrical septal hypertrophy, the left ventricular outflow tract is going to be greatly narrowed. See, this type of obstruction is not fixed. It is not fixed. It is a dynamic obstruction. It's a dynamic. Okay, see for example, if there is aortic stenosis, it's a fixed obstruction. During systole, during diastole, it's a fixed obstruction. But now it is changing, the obstruction is changing. Okay, now during systole there is anterior displacement. Okay, there is anterior displacement of the mitral wall, systolic anterior displacement of the mitral wall. So more stenosis, more obstruction is going to be there. So that's why this obstruction is called as a dynamic left ventricular outflow tract obstruction. It's not a fixed obstruction. Okay, this is a keyword. And next thing, because of the subaortic stenosis in HOCM, there is a murmur present. Okay, there is a murmur present. So what is this murmur? Whenever the left ventricular outflow tract is obstructed, okay, so the left ventricular outflow tract is obstructed. So what happens? There is a murmur which is called as crescendo-decrescendo murmur. Okay, so there is a crescendo-decrescendo murmur or crescendo-decrescendo murmur. Okay, for example, the phase between S1 and S2 is called as systole, and the phase between S2 and S1 is called as a diastole. We know this. Okay, now what happens? See, during systole, when the left ventricle is contracting, there is obstruction. Now, as there is obstruction, what happens? See, now the left ventricle is contracting with higher pressure. Now, higher pressure is there. Initially, there will be more blood will be there, more pressure is generated. So, when the blood is going into the aorta, the murmur intensity increases. Later, the murmur intensity decreases. So, increase in murmur intensity followed by decrease in murmur intensity. So, this is called as crescendo-decrescendo murmur. The murmur will be something like this. The murmur intensity increases and decreases. It's a crescendo-decrescendo murmur. Simple. Remember, try to understand like this. See, there is left ventricular outflow tract obstruction. Look here, guys. What is happening? There is left ventricular outflow tract is obstructed. There is subvalvular aortic stenosis, dynamic left ventricular outflow tract obstruction. When the blood is going through such a narrow area, will it cause sound or not? Yes, definitely it will cause sound. And how it is going to cause a sound? How it is going to cause a murmur? Initially, there will be more blood here. In the left ventricle, more blood will be there. When more blood is there, when more blood is going out of the aorta with more speed, with more pressure, the intensity of murmur increases. Later, the intensity of the murmur decreases. So, increase in the intensity followed by decrease in the intensity. See, this is called as a crescendo-decrescendo murmur. Okay, done. So, crescendo-decrescendo murmur is going to be seen. Along with that, because of this SAM, systolic anterior movement of the systolic anterior movement of the mitral wall, there is also mitral regurgitation. Remember, there is mitral regurgitation. Okay, mitral regurgitation. See, this mitral regurgitation can lead to holosystolic murmur. Holosystolic murmur means during systole, during the complete systole, the blood is getting regurgitated back into the left atria. Okay, see, mitral regurgitation, there is regurgitation of blood into left atria. Okay, see, this will cause holosystolic murmur. It will cause a sound that is called as a holosystolic murmur. During systole, throughout the systole, blood is getting into the aorta as well as into the left atria. The regurgitation of blood back into the left atria will cause the holosystolic murmur. Okay, done. Now, after this, what else you should know is, now, whenever you see an young athlete, okay, whenever you see an young athlete, he is going through the young athlete, okay, not a professional, just in school, okay, he is going through the sports activity, he is participating in some sports activity and suddenly he is having death, he is dead, sudden cardiac death, okay, now he is having sudden cardiac death, SCD. Now, what might be the reason? It's the reason whenever this non-professional young athlete, whenever he is going through the sports activity, now he is having the sudden cardiac death. What might be the reason? He is having hypertrophic obstructive cardiomyopathy, HOCM. Now, what is the cause? Why he is dead? See, this is not because of myocardial infarction. This hypertrophied myocytes, this myocardial cells, The mutated myocardial cells, they are more susceptible for whenever you increase their activity, whenever you cause some ischemia to them. Now they are more susceptible to ventricular fibrillation. Okay, so this ventricular fibrillation is the one which kills the patients. So now important point is this hypertrophied myocytes, they are prone to arrhythmias. Important, they are prone to arrhythmias. So in the young athlete who is involved in some like sports activity, if he is having sudden cardiac death, the reason is arrhythmia, and the most common arrhythmia is going to be ventricular fibrillation. This ventricular fibrillation, whenever there is ventricular fibrillation, the cardiac output decreases, BP decreases, there is crashing of BP and the patient will die. Okay, so this is the important point which I want you to know. And how to treat this condition. Before treatment, let me also add some more important points which are especially important from the point of medicine. Okay, same. If you increase the, for example, let me give an example. If you do squatting, okay, if you do squatting or standing, okay, or Valsalva, okay, squatting, standing, or this Valsalva maneuvers, what they actually do? Okay, will they increase the intensity of the murmur or will they decrease the intensity of the murmur? See, to understand this, even before understanding this, I want you to know that end diastolic volume, okay, is inversely proportional to, or I should say the end diastolic volume is directly proportional to, not inversely proportional to. If more is the end diastolic volume, if you increase the end diastolic volume, what happens is the stenosis, sorry, inversely proportional to it, I'm little just confused, sorry, the end diastolic volume, it is inversely proportional to the stenosis. Okay, so try to understand like this. If you increase the end diastolic volume, if you put more blood, if you put more preload into the left ventricle, now what happened to the left ventricle? Now the left ventricular cavity size will start to enlarge. This preload will force the left ventricle to dilate like this, okay, to distend. So whenever the left ventricle is distending, what happened to the stenosis? The stenosis will decrease. The stenosis, the subvalvular stenosis will decrease. Okay, remember this point, this is very important. The end diastolic volume is inversely proportional to the stenosis. Okay, and the preload, end diastolic volume is nothing but it's a measurement. It's a measurement of the preload, right? So if you increase the end diastolic volume, the stenosis component is going to decrease. Subvalvular aortic stenosis will decrease. Now, whenever you do squatting, what happens? Think logically and tell me. What happened to the stenosis? What happened to the murmur? Okay, whenever you do the squatting, all the veins in the lower extremities are going to be compressed. If all the veins are compressed, what happened to the venous return? Venous return increases. Whenever the venous return increases, what happened to the preload? Okay, the preload increases. Whenever the preload increases, what happened to the end diastolic volume? End diastolic volume also increased. The preload and end diastolic volume are not the same. Whenever the end diastolic volume is increased, what happened to the stenosis? The stenosis is going to be decreased. Whenever the stenosis decreases, what happened to the murmur? The murmur intensity decreases. The stenosis is going to be decreased and murmur, the crescendo-decrescendo murmur. Stenosis is decreased, no? So murmur intensity also decreases. Okay, murmur intensity decreases. This is very important. So with squatting, the murmur intensity decreases. But in other conditions, in all the other heart related conditions, with squatting the heart murmur increases. If you put more blood into the heart, more will be the intensity of the murmur. But in this hypertrophic obstructive cardiomyopathy, the end diastolic volume, the EDV, this end diastolic volume, it is inversely proportional to the stenosis. More the preload, more the end diastolic volume, the stenosis will decrease. Okay, the narrowing will decrease. Now with the standing position, you think logically and tell me. When the person is standing erect like this, because of the gravity, there will be venous pooling. Whenever there is pooling, What happened to the venous return? Venous return decreases. Whenever the venous return decreases, what happened to the preload? Preload decreases. What happened to the end-diastolic volume? End-diastolic volume decreases. Whenever the end-diastolic volume is decreasing, see the end-diastolic volume is decreasing. Whenever the end-diastolic volume decreases, what happened to the stenosis? Stenosis increases. Okay, increases. Whenever the stenosis is more the stenosis, more the murmur. Okay, more the stenosis, more the narrowing, more the murmur will be. The intensity of the crescendo-decrescendo murmur is going to be increased. So murmur intensity increases. Okay, this is also the MCQ. In hypertrophic obstructive cardiomyopathy, with the standing position, the murmur increases. With the squatting position, the murmur decreases. And with the Valsalva. Okay, so whenever you are doing Valsalva, what happened to the pressure inside the thorax? The pressure inside the thorax increases. Okay, the pressure inside the thorax increases. Whenever the pressure inside the thorax, whenever it is increased, what happened to the venous return? Already here there is more pressure, so the venous return decreases. Venous return decreases. Whenever the venous return decreases, you know the same thing. Preload decreases, end-diastolic volume decreases, so more will be the stenosis, so murmur intensity increases. Murmur is going to be increased. In the same way, for example, whenever you give nitrates to this patient, okay, so normally whenever you give nitrates, this young athlete came, usually this young athlete who is playing in some football field, he just fell. Now you thought that okay, there might be some myocardial infarction is going on, there is hypoxia. So in order to decrease the preload, whenever you give nitrates, actually there will be more problem to this patient. Do you know why? The problem is because whenever you give nitrates, what happens? There will be venodilation. Nitrates are the venodilators. Nitrates, they are venodilators. Whenever you do the venodilation, what happened to the venous return? The venous return decreases. Whenever the venous return decreases, what happened to the end-diastolic volume? End-diastolic volume or the preload decreases. Whenever the end-diastolic volume decreases, what happened to the stenosis? Stenosis increases. Okay, whenever the stenosis increases, okay, whenever it is increased, what happened to the murmur? Murmur increases. Okay, so with nitrates, in normal conditions, murmur intensity decreases. Why? Because preload decreases, murmur decreases everywhere in all other heart related problems. But this is the one problem, this is the one heart related condition where there is an exception. Whenever you give nitrates, preload decreases but murmur increases. Whenever the preload is getting decreased, the heart chamber will be much more narrowed. There is no blood, it is much more narrowed. When the left ventricular chamber is getting narrowed, automatically the stenosis will be increased. Whenever the stenosis increases, murmur increases. Okay, whenever there is more stenosis, cardiac output greatly falls. Okay, that's why in this condition, in hypertrophic obstructive cardiomyopathy, nitrates are contraindicated. They are contraindicated. Why? Because already the person's cardiac output is very much less. But whenever you give nitrates, it will actually kill the patient. Why? Because giving nitrates, what it is doing? These are the venodilators, yes, venous return decreases, preload decreases, but stenosis is going to be increased. In hypertrophic, again I am repeating, in hypertrophic obstructive cardiomyopathy, don't give nitrates. Because nitrates increases the stenosis component and the stenosis will actually kill the patient. Okay, done. So, next, how to treat this condition? Treatment part. So, the treatment of hypertrophic obstructive cardiomyopathy is this hypertrophic obstructive cardiomyopathy patients. They are at a risk of, see, there is a risk of arrhythmias. That's the main problem. These hypertrophied myocytes, they will go into arrhythmias very easily. So, you need to implant cardioverter defibrillators. Okay, ICDs, implantable cardioverter defibrillators. These are small apparatus. Whenever there is arrhythmia, immediately these implantable cardioverter defibrillators, they will recognize the arrhythmia, they will send the DC shock and they will bring the rhythm to normal. Okay, so these implantable cardioverter defibrillators, yes, they are used in the treatment of hypertrophic obstructive cardiomyopathy, and the main problem in this HOCM is because of the asymmetrical septal hypertrophy. The septum is becoming bulkier, right? So you need to remove that septum. You can remove that septum. That is called as myomectomy. Okay, that's a surgical process. Or you can do something called as alcohol based. You are going to inject alcohol into directly the septal muscle, so that the septal, that extra myocytes will undergo apoptosis, they will die. Okay, alcohol based septal ablation. See, this alcohol based septal ablation can also be used in the treatment of hypertrophic obstructive cardiomyopathy. So HOCM is treated with implantable cardioverter defibrillators, myomectomy can be done, or alcohol based septal ablation can be done. So as a wrap up of HOCM, tell me what are the important points. Is the autosomal dominant condition. Is it a systolic dysfunction or diastolic dysfunction? It's a diastolic dysfunction. Left ventricle is not properly getting filled because of the banana shaped cavities. Okay, see, it's going to be seen in young athletes, or the young athletes who are going to have a sudden cardiac death. This sudden cardiac death is because of ventricular fibrillation. This hypertrophied cardiomyocytes, they will go into arrhythmias more easily. It's an autosomal dominant condition, and usually one of the sibling or one of the parent have died with a sudden cardiac death. Okay. Now this hypertrophic obstructive cardiomyopathy, there is dynamic left ventricular outflow tract obstruction because of asymmetrical septal hypertrophy, as well as systolic anterior displacement of the mitral wall leaflet. Because of the subvalvular aortic stenosis, there is a murmur which is called as a crescendo-decrescendo murmur. The murmur intensity, okay, the intensity of murmur is dependent on the left ventricular end diastolic volume. If more is the left ventricular end diastolic volume, murmur intensity decreases. Okay, that's what I have discussed here. If, see, these four conditions, if you increase the left ventricular end diastolic volume, murmur intensity decreases. If you decrease the preload, if you decrease the left ventricular end diastolic volume, murmur intensity increases. And not only that, these patients with HOCM are also going to have a mitral regurgitation. That mitral regurgitation can lead to holosystolic murmur. These patients with HOCM are treated with implantable cardioverter defibrillators. You can also perform myomectomy or alcohol-based septal ablation. Under microscopy, what is the important point? Under microscopy, you will see myocyte disarray. Okay, so having said that, the first type of cardiomyopathy, hypertrophic obstructive cardiomyopathy, is completed. Now in the next video, we will discuss about the dilated cardiomyopathy as well as the restrictive cardiomyopathy. Hope the video is helpful. Thank you.